complete myelination in the brain of a newborn. So subtle seizures. However, which is the type of neonatal seizure which carries the most serious prognosis? That means it is very, very dangerous. It is myoclonic seizures, where there are jerks like this. These type of jerks which are known to occur. So while the subtype which is associated with the worst prognosis is myoclonic, the subtype which is associated with the best prognosis are focal seizures and hypocalcemic seizures. So worst prognosis, most serious subtype is myoclonic. Best prognosis are focal. Focal means in one half of the body. Probably only the hand is moving like this. Subtle seizures are even smaller than them. Subtle seizures are just fingers moving or one part of the face twitching like this. You do not have the generalized tonic-clonic seizures that are seen in children. No. So please do not get confused. Overall, most common type of neonatal seizures is subtle. The most serious, dangerous type of neonatal seizures is myoclonic. And the neonatal seizures which carries the best prognosis are focal and hypocalcemic seizures. All seizures that occur because of low calcium and all focal neonatal seizures are associated with very, very good prognosis. You hardly see deaths occurring in these children. One question that was asked in AIMS this year, around 4-5 days the AIMS exam was there, the PG entrance exams, and this was a direct question that was asked, and the question that was asked is, which vitamin deficiency is commonly known to precipitate neonatal seizures? It is pyridoxine deficiency. So which vitamin deficiency is commonly known to precipitate neonatal seizures? It is pyridoxine deficiency. Vitamin B6 deficiency is known to precipitate. That is why please remember both pyridoxine deficiency as well as pyridoxine dependence. I'll give you an example. The mother has been during pregnancy on pyridoxine and now the child is born. So the umbilical cord is cut. So the child was dependent on pyridoxine and suddenly the moment the umbilical cord is cut, now the supply of the pyridoxine disappears. This child will also have a seizure which is in a neonate. So neonatal seizures can occur both because of pyridoxine deficiency or because of pyridoxine dependence. Pyridoxine is vitamin B6. And which is the drug of choice for neonatal seizures? The drug of choice for neonatal seizures is phenobarbital. Please remember, we do not give diazepam in the case of neonates. Diazepam, although a very commonly used drug for management of neonatal, for the management of seizures in older children and adults, but diazepam is usually not given in the case of neonates. It can be highly dangerous. It can cause exaggerated respiratory depression. So these are the 7 questions on neonatal seizures that I've tried to summarize. Which is the most common cause of neonatal seizures? Hypoxia. Which is the most common cause of neonatal seizures in the first 24 hours? Hypoxia. Hypoxic ischemic encephalopathy, HIE. Which is the most common subtype of neonatal seizures? Generalized tonic-clonic seizures do not occur in them. So the most common subtype, subtle seizures. Which is the most serious subtype of neonatal seizures? Myoclonic seizures. Which is the seizures which are associated with best prognosis? 2 types of seizures, focal seizures and hypocalcemic seizures. Excellent prognosis in these children. Which vitamin deficiency can precipitate neonatal seizures? It is pyridoxine deficiency. In fact, as I told you, both pyridoxine deficiency as well as pyridoxine dependence can lead to neonatal seizures. And what is the drug of choice for neonatal seizures? It is not diazepam, it is phenobarbital. Okay. Classification systems for the severity of NEC. Classification systems for the severity of NEC. Was which classification system? Remember, which was the classification system for severity of necrotizing enterocolitis? It was Bell staging. However, the classification system for the severity of hypoxic ischemic encephalopathy, brain when it is getting involved. Then we have two systems. One is known as the Sarnat and Sarnat staging system. This is not given in Ghai. The other system which is given in Ghai is the Levine staging system. Levine's staging system. This is the one that is given in Ghai. There are four components. Both of them, Sarnat and Sarnat staging and Levine staging, both of them divide HI into again three stages. Stage 1, which is less dangerous, stage 2, which is more dangerous, and stage 3, which is the most dangerous. So stage 1 is very mild HI, stage 2 is moderate HI, stage 3 is the one which is most dangerous, it is severe HI. Because the Levine staging is given, I won't go into the details, but Levine staging has four components based upon which the child is classified into different staging systems. Can be given by the mnemonic CTSS. Like I told you in APGAR, we were actually APGAR score. Remember APGAR score? There were 5 criteria: appearance, pulse, grimace, activity, and respiration. So we were actually evaluating the child based on 5 criteria. In Levine staging system, we evaluate the child based upon 4 criteria, which are given by CTSS. So just quickly, C stands for consciousness, T stands for tone, S stands for seizures, and S stands for sucking or respiration. These are the 5 criteria, these are the 4 criteria, I'm sorry, based upon which we actually classify HIE according to the Levine staging system. CTSS: consciousness, tone, seizures, and sucking of the child or respiration, breathing of the child. Consciousness, tone, seizures, and sucking or respiration. And based upon these 4 criteria, the child is divided either into a mild HIE stage, stage 1, moderate HIE stage, stage 2, and severe HIE stage, which is stage 3. Sarnat and Sarnat staging is also a staging system of HI, which is not given in many books. It used to be followed in the past, now it is not very commonly used. This also divides the HI into 3 stages: stage 1 mild HI, stage 2 moderate HI, and stage 3 severe HI. This is all that you need to know. So Bell staging system for the classification of severity of NEC, and Sarnat and Sarnat staging system and Levine staging system for the classification of severity of HI, hypoxic ischemic encephalopathy. So I hope you have all written this. So with this, we move on to the second last topic of neonatology, which is neonatal jaundice. Now, just a few words about normal bilirubin metabolism. I'm sure you all know it, so I don't need to tell it in too much of detail. But just in short, heme which is formed from RBCs, is converted to bilirubin, broken down into bilirubin. Bilirubin then binds with albumin in the blood and is taken to the liver. Why it is taken to the liver? It is taken to the liver for conjugation. It is taken to the liver for conjugation. In the liver, In the liver, you have an enzyme which is known as UDP glucuronosyl transferase. UDP glucuronosyl transferase. What is this enzyme known to do? This enzyme is known to conjugate bilirubin. So what does this enzyme do? This enzyme is known to conjugate the bilirubin. And once this bilirubin is conjugated, this conjugated bilirubin then passes into the intestine. Because only a conjugated bilirubin can pass into the intestine and get excreted. If it's an unconjugated bilirubin, it cannot be excreted. So conjugated bilirubin, which is conjugated by which enzyme? UDP glucuronosyl transferase, which is present in the liver. This enzyme is known to conjugate bilirubin. Conjugation only will help in the bilirubin getting excreted. This conjugated bilirubin comes in the intestine for excretion, but in the intestine you have some enzyme that is known as beta glucuronidase. This beta glucuronidase enzyme, which is primarily excreted by the or primarily secreted by the bacteria which are present in the intestine. This beta glucuronidase, from where does it come? It comes from the bacteria which are present in the intestine. This is known to cause deconjugation. So what does it do? It causes deconjugation of the bilirubin. And as I just now told you, if the bilirubin is not conjugated, it will not pass out. So this deconjugated bilirubin will enter back into the blood. This is known as enterohepatic circulation. But if this is not acted upon by beta glucuronidase, that means it remains conjugated. This conjugated bilirubin is then excreted out. So I'll again repeat. Heme, which is produced from the RBCs, gets converted to bilirubin. Bilirubin then binds to albumin and is taken to the liver for conjugation. In the liver, there is an enzyme which is known as UDP glucuronosyl transferase. This is the major enzyme that is responsible for the conjugation of bilirubin. Why is it so important to conjugate the bilirubin? Because only a conjugated bilirubin will be able to be excreted. An unconjugated bilirubin cannot be excreted. So this bilirubin now enters into the intestine. So now it has entered into the intestine to be excreted. If it stays in the intestine for a long period of time, if it stays, ideally it should be excreted immediately because it is in the conjugated form. If it stays in the intestine for a long period of time, there are certain enzymes which are released by the intestinal bacteria. These enzymes are known as beta glucuronidase. What is the main function of beta glucuronidase? They are known to cause deconjugation of the bilirubin. And this deconjugated bilirubin, once the conjugation factor has been removed, this bilirubin now is not able to get excreted, so it will enter back into the circulation. This is known as enterohepatic circulation. So it cannot be excreted, it will enter back into the blood. And again from the blood will enter into the liver, and again after conjugation will enter into the intestine. But if it does not stay in the intestine for long, then this conjugated bilirubin can immediately get excreted without the action of beta glucuronidase. So staying in the intestine for too long, conjugated bilirubin, if it stays in the intestine for too long, it can be dangerous, because then this bilirubin may be acted upon by beta glucuronidase, which deconjugates this bilirubin, and bilirubin can then enter into the circulation again. So you're understanding what I'm trying to say? Bilirubin formed in the blood, enters into the liver, conjugated, enters into the intestine, it should immediately be excreted. If it is not excreted and it remains in the intestine, then it can be acted upon by beta glucuronidase, which will then cause deconjugation, and this bilirubin will enter back into the circulation. And this is all physiology, nothing pediatrics about it. So this is all physiology. Now please remember, here I would like to tell you about a type of jaundice which is known as breast milk jaundice. Please remember there is a general rule that children who are fed breast milk are at a higher risk of developing neonatal jaundice compared to children who are not given breast milk. So this is a slight sort of relative disadvantage, you can say, although this jaundice still does not require treatment in majority of cases, so it's not actually a disadvantage, but a minor disadvantage that you can say is children who are not on breast milk usually are less likely to develop neonatal jaundice compared to neonates who are on breast milk. The main culprit are two important components of breast milk. There are many more, but two important components of breast milk. One important component of breast milk is a component which is known as pregnein 3 alpha. Now, what does pregnein 3 alpha do? Pregnein 3 alpha is an inhibitor of the enzyme UDP glucuronide transferase. I just now showed you UDP glucuronide transferase. Just see the star is known to conjugate the bilirubin, and conjugation is very important for the bilirubin to be excreted. So what is pregnein 3 alpha doing? Pregnein 3 alpha is a component of breast milk and it is known to inhibit this enzyme in the liver. So when UDP glucuronide transferase get inhibited, naturally the conjugation cannot happen, and if bilirubin is not getting conjugated, this bilirubin cannot be excreted. So it will continue to stay in the blood, leading to a prolonged state of neonatal jaundice. Another important component that can lead to breast milk jaundice is the presence of beta glucuronidase. I just now told you that beta glucuronidase are released by the intestinal bacteria. See the second star? Intestinal bacteria. And these are the enzymes that cause deconjugation of the bilirubin. So if the breast milk contains this enzyme, beta glucuronidase, then whatever small amount of conjugated bilirubin is entering into the intestine, this beta glucuronidase which is present in breast milk will cause deconjugation of the bilirubin. So two important problems are happening. First, conjugating enzyme in the liver is getting suppressed by one component which is pregnein 3 alpha. Second, whatever small amount of bilirubin is still getting conjugated is being deconjugated by another enzyme of breast milk which is beta glucuronidase. So neither is the conjugation process proper, and in addition there is additional deconjugation of the bilirubin, both of them contributing to increased amount of bilirubin in the blood, which is the cause of neonatal jaundice. Because this neonatal jaundice is occurring due to the child being on breast milk, that is why this type of neonatal jaundice is known as breast milk jaundice. I hope you have understood breast milk jaundice. Please remember, because breast milk jaundice usually does not require any treatment, it is advisable to continue breastfeeding in the child. So breastfeeding despite the jaundice should not be stopped. Continue breastfeeding. In some foreign books, they have written that breast milk should be stopped for about 24 to 48 hours for this bilirubin to come down. But in India, we probably feel that the harmful effects of not giving a breast milk to a child will be much higher in comparison to a very, very small problem that may be associated. Phototherapy may be required. So what we do is, we normally recommend that despite this being a breast milk jaundice, breastfeeding should be continued. Breastfeeding should not be stopped in the Indian context. Another type of jaundice that you should be aware of is a jaundice which in this case is not because of breast milk but because of breastfeeding. This type of jaundice is known as the breastfeeding jaundice. Please don't compare it with breast milk jaundice. Breast milk jaundice is because of the components of breast milk. Breastfeeding jaundice is because of insufficient breastfeeding. So what is breastfeeding jaundice? Please see this. Insufficient feeding of breast milk early in life. 2 to 3 days. Insufficient amount of breast milk is taken. When the when the breast feeding is very little in the first 2 days of life. All newborns, they take very little amount of breast milk in the first 2 to 3 days of life. This is normal. Gradually, as they start getting adapted to breastfeeding, they start taking more and more feeds. But at least early, breastfeeding is not sufficient. So at least 2 to 3 days, they are sucking less, and therefore, when there is sucking less amount of milk is entering into the intestine. When less milk is entering into the intestinal motility obviously will be low, sluggish, less intestinal motility. And therefore, the bilirubin, which is coming from the liver into the intestine, bilirubin in the intestine, therefore, will stay for a longer period of time. You understand? Because if the bilirubin is coming from the liver into the intestine and intestinal motility is fast, the bilirubin will immediately get excreted. But in this case, what is happening is because of less amount of breast milk entering into the intestine, intestinal motility is less. When the intestinal motility is less, the bilirubin, conjugated bilirubin, which is entered into the intestine, stays for longer period of time. So more time for beta glucuronidase to act. I just now told you of when I was telling you about bilirubin metabolism. If the conjugated bilirubin enters into the intestine, it should immediately pass off, immediately get excreted. Because if it stays for long, the beta glucuronidase, which is secreted by the bacteria, will cause deconjugation of this bilirubin. And when this bilirubin gets deconjugated, it cannot be excreted. It will come back into the circulation. So this form of jaundice, which is not because of components of the breast milk. Breast milk jaundice is because of the components of breast milk, pregnein 3 alpha and beta glucuronidase. But breastfeeding jaundice, as the name suggests, is because of insufficient breastfeeding early in life, which leads to reduced intestinal motility, which leads to bilirubin staying for longer period of time into the intestine, which leads to more time for the beta glucuronidase to act and cause deconjugation of the bilirubin. And therefore, this deconjugated bilirubin will enter back into the circulation. It will not be excreted. So this type of jaundice is known as breastfeeding jaundice. So two types of jaundice, both appear to be like occurring because of breast milk, but no. One is due to the components of breast milk, the other is because of insufficient breastfeeding early in life. Breastfeeding jaundice, because it is due to insufficient breastfeeding early in life. As the breastfeeding will improve by day 4 to day 5, this jaundice will disappear. So the second type of jaundice, breastfeeding jaundice, will disappear very quickly. So by 4 to 5 days, 6 days, it will disappear as the child starts taking more and more milk. So as the child starts taking more and more milk, intestinal motility will improve. And when the intestinal motility will improve, then this conjugate bilirubin can pass. But breast milk jaundice, because it is due to the components of breast milk, it often stays for as long as 2 to 3 weeks. So it is a prolonged neonatal jaundice. I hope everyone has understood this. So let me now immediately move on again to the slides. So first thing that you need to know whenever there is neonatal jaundice, that is this a neonatal jaundice, physiological jaundice or a pathological jaundice? So there are certain criteria for a physiological jaundice. So what are the criteria for a physiological jaundice? Any jaundice which appears between 24 to 72 hours of life, never in the first 24 hours. Any jaundice which appears between 24 to 72 hours of life is likely to be a physiological jaundice. The jaundice which is physiological will never appear in the first 24 hours of life. Second, any jaundice which disappears usually by 2 weeks. In some cases it can persist till 3 weeks, but in majority of cases it disappears by 2 weeks. So any jaundice which disappears by 2 weeks is again likely to be a physiological jaundice. And any jaundice where the serum bilirubin levels are less than 15 milligrams per deciliter is again likely to be a physiological jaundice. So there are three primary criteria for a physiological jaundice. What are the three primary criteria? The jaundice which appears between 24 to 72 hours of life is a physiological jaundice, never in the first day. Second, jaundice which disappears by 2 weeks is usually a physiological jaundice. And jaundice where the serum bilirubin levels never cross 15 milligrams per deciliter is a physiological jaundice. So I hope you have understood. Any jaundice which appears between 24 to 72 hours is physiological. Any jaundice which persists till 2 weeks and then disappears is physiological. And any jaundice where the serum bilirubin levels are less than 15 milligrams per deciliter, never cross 15 milligrams per liter, is a physiological jaundice. Physiological jaundice are nothing to worry about because they are due to normal physiology of a newborn. So there is nothing to do in these cases. Majority of cases, they do not require any treatment also. It's the pathological jaundice which are causes of worry and which needs to be managed. So when do we call a jaundice as a pathological jaundice? So a pathological jaundice is therefore a jaundice which follows these criteria. Any jaundice within 24 hours of life will be a pathological jaundice. Any jaundice which persists beyond 2 weeks will be a pathological jaundice. Then any jaundice where the serum bilirubin levels are more than 15 milligrams per deciliter will be a physiological jaundice. And any jaundice where the serum bilirubin rises more than 5 milligrams per deciliter per day will be a pathological jaundice. Sometimes another criteria they say is conjugated bilirubin. More than 2 milligrams per deciliter, which means a conjugated jaundice. Will also be called as a pathological jaundice. So there are 5 main criteria of pathological jaundice. Any jaundice which appears within 24 hours of life is a pathological jaundice. Any jaundice which persists for more than 2 weeks is a pathological jaundice. Remember, physiological jaundice usually disappear within 2 weeks. So any jaundice which persists beyond 2 weeks is a pathological jaundice. Any jaundice where the serum bilirubin levels are more than 15 milligrams per deciliter is a pathological jaundice. So primarily the first 3 criteria are just opposite of these first 3 criteria. So any jaundice which is known to occur within 24 hours will be pathological. Any jaundice which persists for more than 2 weeks will be pathological. Any jaundice where the serum bilirubin levels are more than 15 milligrams per deciliter will also be pathological. Then any jaundice where the serum bilirubin levels are rising more than 5 milligram per deciliter per day. In one day, the levels rise more than 5 milligrams per deciliter. Yesterday it was 10, today it is 18. That means in just 24 hours, the rises from 10 to 18, 8. So if the level rises more than 5 within 24 hours, it is actually one of the indications that this jaundice is pathological. And any jaundice in which the conjugated bilirubin is raised more than 2 milligrams per deciliter, conjugated bilirubin, is likely to be a pathological jaundice. Unconjugated hyperbilirubinemia may not be damaging. It is the conjugated hyperbilirubinemia which is dangerous and damaging. So I'll just repeat again. Any jaundice which occurs within 24 hours will be pathological. Any jaundice which persists for more than 2 weeks will be pathological. Any jaundice where the serum bilirubin levels are more than 15 milligrams per deciliter is pathological. Any jaundice where the serum bilirubin levels rises more than 5 milligrams per deciliter per day will be pathological. And any jaundice in which the conjugated bilirubin is more than 2 milligrams per deciliter, that means this is a conjugated jaundice family. This will also be pathological. Unconjugated jaundice can be physiological. Conjugated jaundice nearly always is pathological. What is meant by conjugated jaundice? When the conjugated bilirubin, you know, there are two types of bilirubin, unconjugated and conjugated. When conjugated bilirubin is more than 2 milligrams per deciliter, usually, then it is an indication that this is a case of pathological conjugated jaundice. And pathological conjugated jaundice always requires treatment. Okay. What are the causes of pathological jaundice? So pathological jaundice causes, let us talk about the first and the most important cause of pathological jaundice is blood group incompatibility. So Rh, ABO incompatibility or any hemolytic disease in which there is breakdown of the RBCs. For example, G6PD deficiency. Any disease in which there is breakdown of the RBCs, G6PD deficiency, elliptocytosis, heterospherocytosis. All of these are likely cause of neonatal jaundice and blood group incompatibility, Rh and ABO incompatibility. Then torch infections, toxoplasmosis, rubella, cytomegalovirus, herpes. Many of these torch infections are known to cause jaundice in neonates. For example, a congenital rubella is an important cause of jaundice in neonates. A congenital cytomegalovirus infection is a common cause of jaundice in neonates. So many of these congenital infections are known to cause jaundice in neonates. Then a congenital hypothyroidism is a very important cause. Any neonatal jaundice, the thyroid function test of the newborn should always be done. As such, thyroid function tests are recommended now in all newborns routinely for screening. But in the case of neonatal jaundice specifically, if a congenital hypothyroidism has not been ruled out, you should rule it out by doing a thyroid function test. Then neonatal sepsis, neonatal infections, again is an important cause of neonatal jaundice. Hereditary defects in bilirubin metabolism. Which are the hereditary defects in bilirubin metabolism? The hereditary defects in bilirubin metabolism are Crigler-Najjar syndrome, Gilbert syndrome, then Dubin-Johnson syndrome, and Rotor syndrome. So four important defects in hereditary defects of bilirubin metabolism. Which are the four important hereditary defects? Crigler-Najjar syndrome, Gilbert syndrome, Dubin-Johnson syndrome, and Rotor syndrome. Out of these two, the lower two, are always conjugated, while the upper two are always unconjugated. So D, Dubin-Johnson, R, Rotor syndrome are the two conjugated jaundice. That is why I always tell DRR conjugated. What is meant by DRR conjugated? Dubin-Johnson's and Rotors are conjugated, while Crigler-Najjar and Gilbert's are unconjugated. These are the four types of hereditary defects in bilirubin metabolism. Then children who are born to diabetic mothers, these children also have increased risk of neonatal jaundice. If you go back to the complications that I told you in infants of diabetic mothers, complications, I gave you a mnemonic: low cost MRP. L was LGA, C was congenital malformations, M was metabolic complications, R was respiratory disorders, and then I told you P was polycythemia and its consequences. And one of the consequences of polycythemia was jaundice, if you remember. So infant of diabetic mothers, increased risk of neonatal jaundice. Then even a Keffel hematoma, we discussed about caput secundum and Keffel hematoma. So it's a swelling which is collection of blood. And if it's a collection of blood, obviously it means it's a collection of RBCs. So Keffel hematoma also will be likely to cause jaundice because it's a collection of RBCs, and these RBCs, when they'll break down, bilirubin will be released. And finally, neonatal hepatitis is another cause of neonatal jaundice, always a cause of conjugated neonatal jaundice. Neonatal hepatitis never leads to unconjugated neonatal jaundice. Neonatal hepatitis always is a cause of conjugated neonatal jaundice. Right? So let us summarize these causes of neonatal jaundice once again. Blood group incompatibility, which means RH and ABO incompatibility, or any hemolytic disease of the newborn. Hemolytic disease means where there are breakdown of the RBCs. Then congenital infections. Torch infections are important causes again of neonatal jaundice. Congenital hypothyroidism, another important cause of neonatal jaundice. Sepsis, infections, septicemias, they are again important causes of neonatal jaundice, infections. Then hereditary defects in bilirubin metabolism. Which were the hereditary defects? You can see at the bottom: Crigler-Najjar syndrome, Gilbert syndrome, Dubin-Johnson syndrome, and Rotor syndrome. In these, the bottom two are conjugated jaundice, the upper two are unconjugated jaundice. So that is why I always say doctors are conjugated, D are conjugated. So Dubin-Johnson and Rotors are always conjugated jaundice. Then infants of diabetic mothers, then Keffel hematoma, RBC production because, RBC collection in the scalp. It's a blood collection in the scalp, Keffel hematoma. So because it's a blood collection, it's a collection of RBCs, which when break down will lead to neonatal jaundice. And the last cause of neonatal jaundice is a neonatal hepatitis, which usually is a cause of conjugated neonatal jaundice. I hope you have all written. So once jaundice has been diagnosed, how do you know the levels of the serum bilirubin? A very approximate way of knowing the levels of serum bilirubin is the Kramer's rule. So just pay attention to what I am saying first. Please pay attention to what I am saying. When the icterus is present on the face, the levels are 5 milligrams per deciliter. When the icterus comes down to the chest, the levels are 10 milligrams per deciliter. When the icterus comes down now to the abdomen up to the thighs, then the levels are 12 milligrams per deciliter. When the icterus is throughout the body, but not in the palms and soles, level are 15 milligrams per deciliter. And when the levels are when the icterus is now in the palms and soles also, levels are more than 15 milligrams per deciliter. So you have to watch the increase in the icterus in the body. So if the icterus is present on the face, the levels are 5 milligrams per deciliter. Icterus is on the face and on the chest, but the lower half of the body is not affected. So the levels are 10 milligrams per deciliter. Icterus is on the face, on the chest, and now is on the abdomen and thighs also. So till the thighs, the whole body is yellow. But below thighs, the body is not yellow. Levels are 12 milligrams per deciliter. Now the whole body has become yellow from head down to the legs, but the palms and soles are still not yellow. Levels are 15 milligrams per deciliter, and the moment the palms and soles also become yellow, then the levels are more than 15 milligrams per deciliter. So I'll write it here. Till the head, 5. Till the chest, it is 10. Then abdomen and the thighs, it is 12. Then whole body, it is 15. And when the palms and soles are also affected, plus the palms and soles, then it is more than 15. Head, only yellow, 5. So the levels of total serum bilirubin, I'm telling you about the levels of total serum bilirubin. So only the head is yellow, levels of total serum bilirubin are 5. Head, chest is yellow, levels of total serum bilirubin are 10. If head, chest and the abdomen is also become yellow, levels of total serum bilirubin are 12. If the whole body is affected, but the palms and soles are still not yellow, then the levels are 15 milligrams per deciliter. And if the palms and soles also get affected, then the levels of serum bilirubin are more than 15 milligram per deciliter. This rule is known as the Kramer's rule. It's a rough evaluation of the levels of total serum bilirubin by observing the presence of yellowness, the icterus, over the child's body. But obviously, the gold standard method for diagnosing neonatal jaundice is always total serum bilirubin estimation. What is the gold standard method? It is total serum bilirubin estimation. There should be no confusion. The gold standard method for diagnosing neonatal jaundice is total serum bilirubin estimation. That is by testing. Kramer's rule is just a rough guide. Kramer's rule is just a rough guide which can tell you the levels of bilirubin. It's a visual guide, but it is not an actual method. What is the actual method to assess the method of total serum bilirubin? It is total serum bilirubin estimation. So I'll repeat again. Face, levels are 5, levels of total serum bilirubin. Face and chest, levels are 10. Face, chest and abdomen, levels are 12. Face, chest, abdomen, thighs, and in fact the whole of the body till the legs. But the palms and soles are still not affected. Levels are 15. And when the palms and soles also get affected, that means the total serum bilirubin levels are more than 50. This method of visual diagnosis of icterus is known as the Kramer's rule. But this is not a gold standard method. The gold standard method for diagnosis of neonatal jaundice is total serum bilirubin estimation. Finally, once you have diagnosed jaundice and you know what is the levels of the total serum bilirubin, once everything has been done, the last thing that remains is how do you treat neonatal jaundice? So for the treatment of the neonatal jaundice, there are two main methods. One is known as phototherapy and one is known as exchange transfusion. Phototherapy, basically speaking, is a light which falls over the child. It's a blue light which falls over the child, and the wavelength of the light that is used is normally 460 to 490 nanometers. There is an FMG question that was asked, which is there in your question banks also, where a picture like this was shown, and the question that was asked is what is the wavelength of light that is used in this machine. So this is a phototherapy machine, and the wavelength of light that we normally use is 460 to 490 nanometers. Basically, what is a phototherapy known to do? It is known to convert bilirubin into soluble isomers by three reactions. Which are the three reactions? The first reaction is structural isomerization. The second method is configurational isomerization. And the third method is photooxidation. Structural isomerization is the most effective method by which phototherapy works, where it converts bilirubin into lumirubin. Configurational isomers, here the configuration of the bilirubin is changing, where Z bilirubin is converted to E isomers of bilirubin. So structural isomerization, bilirubin is converted into its structural isomer, which is lumirubin. Configurational isomerization, here it is changing the configuration of the bilirubin molecule to make it soluble. So Z isomers of bilirubin are converted to E isomers of bilirubin to make it soluble. And the third mechanism by which phototherapy converts bilirubin into soluble forms is photooxidation. Out of structural isomerization, configurational isomerization, and photooxidation, the most effective method by which phototherapy works is structural isomerization. Does phototherapy have any side effects? Yes, side effects of phototherapy includes diarrhea, dehydration. Dehydration of a child who is kept under phototherapy is very, very important. Dehydration. So the child should be given breastfeeding as frequently as possible. Every 2 to 4 hours, the mother should be called in the nursery or NICU to give the child breastfeeding, if the child can take breastfeeding. The reason is children under phototherapy can become dehydrated very quickly. Another important complication of phototherapy is hypocalcemia. So if you have given phototherapy for more than 72 hours, phototherapy has been given for more than 72 hours, it is advisable that serum calcium in these children should be checked, because hypocalcemia is an important complication of phototherapy. And then the phototherapy can also have a bronzing effect over the child's body. This is a bronzing effect over the child's body, which is known as the bronze baby syndrome. And the bronze baby syndrome usually is a complication of phototherapy. Complication of phototherapy. So the primary complications of phototherapy are diarrhea, dehydration, hypocalcemia, and bronze baby syndrome. In addition, retinal damage, damage to the retina is also quite common in these children, and that is, you can see the eyes of the child, just see the retinal damage. So eyes of the child usually are always covered when the child is kept under the phototherapy unit. You can see the eyes of the child have been covered because damage to the retina has been shown to occur whenever the child is kept under the phototherapy machine. So apart from damage to the retina, other complications that can occur in phototherapy are diarrhea, dehydration, hypocalcemia, and a complication which is known as bronze baby syndrome. A second method, less commonly used, but nevertheless you should know about this method. A second method which can be used for treating jaundice, especially when the neonatal jaundice becomes very high. When it is manageable, it can be treated by phototherapy. So you are putting the child under a phototherapy unit, and by giving a wavelength of 460 to 490 nanometers, bilirubin is getting converted to soluble isomers. So bilirubin is getting excreted. But suppose the bilirubin levels become very, very high, and there is an immediate risk that this bilirubin can cross the blood-brain barrier and can cause damage to the brain, kernicterus. In that cases, immediate treatment can be done by an exchange transfusion. So here what we do is, we actually exchange the whole of the child's blood. So we remove the blood in 5 or 10 ml aliquots from one side. So put in a cannula and remove the blood from one side, and another blood that has been brought from the blood bank can be infused from the other side. So removing the blood from one side, infusing a blood from the blood bank from the other side. So you are changing the child's blood with a donor blood which has been brought from the blood bank. How much donor blood is usually required? That basically normally is given by a simple formula, 80 ml per kg. So if you are doing exchange transfusion with 80 ml per kg of blood, this is known as a single volume exchange transfusion. But if you are doing exchange transfusion with double the volume, 160 ml per kg of blood, this is known as double volume exchange transfusion. It is known as double volume exchange transfusion. This is the one that is commonly used nowadays during exchange transfusions. You understand? Please try to understand. In an exchange transfusion, what we are doing is we are removing the child's blood and exchanging it with the blood which has been brought from the blood bank. Now, how much of blood is being used from outside, the donor's blood? How much of it being used to perform an exchange transfusion? Change transfusion with 80 ml per kg of blood. Suppose the child's weight is 3 kgs. We are doing exchange transfusion in a child who is 3 kgs, and suppose we are using 80 ml per kg. He is 3 kgs, so we are doing 240 ml exchange. This will be called as a single volume exchange transfusion. What is it called? Single volume exchange transfusion. This is less commonly performed. More commonly performed is a exchange transfusion where we are exchanging how much of donor's blood? 160 ml per kg of donor's blood. So normally if the child is 3 kgs, I will perform an exchange transfusion in this child, 3 kgs, with 160 multiplied by 3, that is 480 ml of blood. This is known as a double volume exchange transfusion. Single volume exchange transfusion with 80 ml per kg blood, double volume exchange transfusion with 160 ml per kg blood. Which is the one which is more commonly used? The one which is more commonly used is a double volume exchange transfusion. Does exchange transfusion have its own complications? Yes. One complication again is hypoglycemia. So glucose should be given during exchange transfusions because these children can go into hypoglycemia. One complication can be hypocalcemia, and these children can have alkalosis. Now the blood that we bring from the blood bank normally contains citrate as a preservative. This citrate, when it enters into the body of a neonate, it can cause alkalosis. So alkalosis is one of the complications that can occur during exchange transfusion. Alkalosis because of citrate which is present in the blood bags. Hypoglycemia, hypocalcemia, alkalosis are the complications of exchange transfusion. Diarrhea, dehydration, hypocalcemia, and bronze baby syndrome are complications of phototherapy. If the jaundice is not very high, we normally perform phototherapy. If the jaundice becomes very high and it is almost like kernicterus is about to happen, then for emergency purposes, we perform an exchange transfusion. Exchange transfusion can be performed with an 80 ml per kg of blood, single volume exchange transfusion, or 160 ml per kg of blood, double volume exchange transfusion. This kg is the weight of the child in whom exchange transfusion is being performed. So before we take a lunch break, was very quickly what we did after the previous break. So I talked about certain important benign problems that were seen in the newborns. Then I talked about hypoxic ischemic encephalopathy and birth asphyxia. Birth asphyxia or perinatal asphyxia is lack of blood supply. And whenever there is lack of blood supply to the child and hypoxia to a child, a newborn, then it can result in the brain being the first organ to get affected. But this does not happen. Brain is not the first organ to get affected. Why? Because the blood from different organs of the body is preferentially diverted towards the brain to protect the brain. So kidney, intestines, liver, lung, all of them start chipping in to protect the brain. So brain is eventually involved. Ultimately, initially, it is kidneys, intestines, they start getting involved. So whenever the blood is getting diverted away from the kidneys, acute renal failure. Whenever the blood is getting diverted away from the intestine, so intestinal ischemia, necrotizing enterocolitis. Necrotizing enterocolitis, predominantly a problem of preterm infants. Term infant will develop NEC only when there is a birth asphyxia, but preterm can develop NEC even without a birth asphyxia. So in a preterm child, you start bottle milk or formula milk very early. It will cause colonization of the intestine with bacteria. Once there is colonization of the intestine with bacteria and milk, both increase the oxygen demand inside the intestine. There is already less amount of oxygen, and the oxygen demand of the intestine increases, so there will be intestinal ischemia. Damage to the intestinal mucosa will expose the toll-like receptors below, to which the bacteria bind, causing intestinal inflammation and damage. So once the intestinal inflammation and damage occurs, there can be air entering into the intestinal wall, which is known as pneumatosis intestinalis. Air entering into the portal vein, pneumoportalis, and air finally entering into the peritoneal cavity, which is pneumoperitoneum. Whole septicemia can occur. What is the classification system for severity of NEC? Bell staging system. But when brain finally gets involved in this condition, perinatal asphyxia, this condition is known as hypoxic ischemic encephalopathy. Problem can happen in the brain of a term infant, preterm infant. What are the type of damages that occur in the brain of a term infant? I told you the first damage is selective neuronal necrosis in the watershed areas of the brain, watershed infarcts. Everything is just revision now. Second is mushroom-shaped gyries are formed, and the third is selective neuronal necrosis of the basal ganglia, a condition which is known as status marmoratus, which is the only type of ischemic brain injury in preterm infants. Necrosis of the white matter around the ventricles, periventricular leukomalacia, leading to which type of hydrocephalus? A normal pressure hydrocephalus ex vacuum. What is the classification system for HIE, hypoxic ischemic encephalopathy? One is Sarnat and Sarnat staging, and the other is Levine staging. For NEC, it was Bell staging. Then whenever hypoxic ischemic encephalopathy occurs, neonatal seizures can occur. The most common cause of neonatal seizure? HI, hypoxia. The most common cause in first 24 hours? Hypoxia, HI. The most common subtype of neonatal seizures? Subtle seizures. The neonatal seizures worst prognosis? Myoclonic. Best prognosis? Focal and hypocalcemic. Which vitamin deficiency precipitates neonatal seizures? Pyridoxine. And drug of choice? Phenobarbital. Then I talked about neonatal jaundice, physiological jaundice, pathological jaundice. Physiological jaundice normally occurs between 24 to 72 hours, never in the first day. Total serum bilirubin always less than 15 milligrams per deciliter, and physiological jaundice do not persist beyond 2 weeks. If a jaundice persists beyond 2 weeks in a newborn, if the jaundice appears within 24 hours in a newborn, if the jaundice total serum bilirubin level is more than 15 milligrams per deciliter in a newborn, if the levels rise more than 5 milligrams per deciliter per day, and the conjugated bilirubin is more than 2 milligrams per deciliter, this is pathological jaundice. So many causes of pathological jaundice I told you: blood group incompatibility, torch infections, septicemias, hereditary defects in bilirubin metabolism, infant of diabetic mothers, hepatitis. Then what is the Kramer's rule? Visual inspection of jaundice. So if the face is yellow, levels are 5. Face and chest is yellow, levels are 10. Face, chest, abdomen and thighs are yellow, levels are 12. The whole body is yellow except palms and soles, level are 15. And if the palms and soles are also yellow, the total serum bilirubin levels are more than 50. Treatment of neonatal jaundice is phototherapy in exchange. Phototherapy, the light that we use is between 460 to 490 nanometers. 3 reactions occurring in phototherapy which convert bilirubin into soluble isomers: structural isomerization, configurational isomerization, photooxidation. Most important method by which phototherapy works: structural isomerization, where lumilubin is formed. Then side effects of phototherapy can be dehydration, can be diarrheas, can be bronze baby syndrome, can be hypocalcemias, can even be retinal damage. Exchange transfusion can be a single volume exchange when it is performed with 80 ml per kg of blood, double volume exchange 160 ml per kg of blood. Exchange transfusion can also be associated with some complications, especially hypocalcemia, hypoglycemia and alkalosis, which is because of citrate which is present in the blood bags. So I hope till here you have understood everything. Just one last topic which will remain in neonatology, which is hyaline membrane disease, which I'll talk after the lunch break, and then we'll start with congenital heart disease. So I'll log out from here. After 1 hour, we'll start again with the last session of today's class. I hope you